And so a lot of you have gotten comments back, because it's pretty easy to see on the code summary for patients that are in arrest. You can just look down and see when does the capnography appear. And you can just see, oh, it's 8 minutes into the code, it's 3 minutes into the code, it's 20 minutes into the code. So the idea is to do that, if possible, at the very beginning of your code. Now, understood, depending on how many people show up and how chaotic it is and what's happening, that might not be your ultimate priority in the first, bit. But we're also doing a non-rebreather in a lot of our patients. So so positive pressure doesn't even appear for a few minutes into the code anyway. So so it seems like when you start bagging, should be a good time to put the capnography on. As an aside, tangent alert, non-rebreather for cardiac arrest. Who gets the non-rebreather when you show up, and who should get mask ventilation from the first second that you get there, assuming that you have enough hands and you're not just like trying to, put an AED on or start compressions. Let's just say you walk in with, 4 or more people, and you have hands. Which cardiac arrests should we be bagging right away? Which cardiac arrest should get a non-rebreather?
Like a witness?
More hands, bag them.
Okay, so we'll assume you have enough hands no matter what. When do you put the non-rebreather on? Even if you have 10 people in the room, when do you bag, assuming you have enough people? So witness kind of ties into this. Super important. Sounds like we're probably not doing this consistently well. So why do we run some codes with a non-rebreather? We should be running a lot of our codes with only a non-rebreather.
The initial idea should be to just give them oxygen and start going that way, and then free up hands to start doing other things.
So interestingly, it has nothing to do with the number of hands you have. It's an added benefit if you don't have a lot of hands, but that's not the intention.
The only thing I can think of is if you're having difficulty getting to the patient, like if a patient on the bed.
I'm going to say the patient drops right here, right now. All of us in the room, we have all the ALS equipment sitting right here. Who am I going to put a non-rebreather on, and who am I going to bag? Adults.
Does it have to do with the rhythm? Asystolic or?
Patient size? Possibly just size then? If it's a bigger person or if it's a relatively smaller person?
Both of us all the time. All the time.
Trick question.
Every patient.
So why would we not bag a patient if we have all the means and resources to bag a patient who's not breathing? And if you are bagging every patient, then you're potentially killing people. So if your goal, if your mindset when you run into a cardiac arrest is who's going to bag straight to bagging, then you're doing it wrong. Absolutely doing it wrong. And this has been in our teaching for about 5 years. Okay. Maybe more than 5 years. Why would we not bag a patient? Why is bagging bad? Yes, right? We just talked about that. Overventilation kills. So we don't even 6 cc's per kilo in a patient, even the 300 cc's, 400 cc's, 500 cc's on a ventilator, in a patient who's in cardiac arrest, is decreasing venous return because they have so little venous return. So we would really like to not put any positive pressure in there if we don't have to. So there's pretty good evidence that for at least the first 3 rounds of 200 compressions, it may work longer than that, but we just haven't had human studies that have extended it. If you put a non-rebreather on somebody and you're pressing on the chest, every time there's recoil of the chest, you're sucking some oxygen in. Okay? And they don't need that much oxygen. You know, they need some, but they don't need that much. So at least for the first few minutes, that's great. But that only works for patients who started with relatively normal oxygen in their lungs. So if somebody has a sudden cardiac event, the classic VFib arrest, and they drop, what percentage of oxygen is in their lungs when they drop?
Upper 80s.
Well, not the percentage, like ambient air.
Oh, 21.
Yeah, roughly just 21%, right? They were breathing. That's all of a sudden their heart fibrillates, they drop. They still have oxygen in their lungs. Not as, you know, it's 21% for a few minutes. That's why compression-only CPR works, because they're using the oxygen that's already in the lungs. And their CO2 should have been about normal. Those patients who have our best chance of saving, we want to protect their brain as best we can. So those are the patients who we want to put a non-rebreather on. Just avoid positive pressure for a few minutes. Do good CPR. Focus on the defibrillation. Focus on early epi. And then get your stuff ready for whatever your positive pressure mode's going to be. Bagging, LMA, ET tube. And then at 3 rounds into this, it's like, okay, we haven't converted the patient. We don't have a quick ROSC, which you sometimes get in those VFib arrests. Now it's time to put in and go switch to positive pressure ventilation with capnography. If that patient had a respiratory event that caused their code, give me an example of a respiratory event that causes a code that we see every day. Well, we don't see, that one is a respiratory event, but give me something we see every day. What makes people code? Has anybody been to a code lately? Give me some examples of codes.
Choking.
Choking?
Aspiration.
Okay, aspiration. PE is respiratory too. What else? How about anybody been to an overdose in the last year? Okay. Classic respiratory event. A hanging? Classic respiratory event. Patient slowly, they stop breathing, their CO2 climbs, their sat drops, and then they over 5, 10, 30 minutes, depending on the situation, that's where they code. So by the time you show up, what do you think, if the normal CO2 level in the blood should be about 40, what do you think their CO2 is? They haven't been breathing off. They're still there. They didn't code right away. So they were still, their heart was still beating. They still had metabolism going on in their cells, but they just barely could get any of it out because they're barely breathing. What's happening to their CO2? Is it going up or down? It's going up. How often have you seen this where you first put the capnography on? You'd see it more if you put it on early in the code, and you have a CO2 of 80, 100, 120, right? They had a respiratory event. So you can usually tell pretty quickly from probably the dispatch information, you probably have a reasonable guess, and you may not be 100% right, but you have to go with your guess. But if it's overdose, if it's strangulation kind of event, or if it's somebody who the initial call comes out as difficulty breathing, and then you walk in and family says, yeah, they've been having trouble breathing for the past 2 hours, and then while you get there, then they code, respiratory event, right? As opposed to the story of, no, they were just out for a run and they dropped. They were just having dinner, they were fine, we were talking and they dropped. Cardiac event, respiratory event. Cardiac event, non-rebreather, minimize our positive pressure, focus on other things, even if you have all the hands in the world. Respiratory event, go straight to bagging. Don't overbag, but go straight to bagging. Does that make sense? So it's a real important distinction. It's a detail, but really important. Okay, and I think we're gonna spend most of our time on bagging today, which is great. All right, so we talked about that. Okay, so monitoring. So capnography. So we started this by saying, hey, we gotta put the capnography on earlier. But why do we have, when we're mask ventilating in the OR, not cardiac arrest, right? This is somebody who comes in, perfectly healthy, elective surgery, always have capnography during mask ventilation. What information can we get from capnography that would make it worth doing that every time? Not a code.
How their breathing is, and if they have any type of, anything going on, you can tell from capnography.
Okay, so like you could tell if they had some obstruction, okay? For example, what's that?
Good exchange.
Yeah, good exchange. What else can you tell from capnography? Can you tell if you're ventilating, if you're over ventilating or under ventilating?
I was going to say adequate ventilation.
How do you tell?
Probably the higher the CO.
Yeah, I mean, you can look at the CO2 level. So if you're bagging for somebody and their CO2, it's nice to know where they start. But if they started normal at 40, not that our patients generally start normal, but let's say they start normal at 40, and then then you notice that now their ventilation is the CO2 is 30, you're like, oh, looks like I'm overventilating. I have to reduce my volume or my rate. Or now their CO2 is 50. Oh, I'm probably underventilating. I have to increase my rate or volume a little bit, my minute ventilation. Now it's a little trickier for us when we're dealing with, by definition, sick people, and their CO2 can be all over the place just based on their underlying physiology, especially if they're really acidotic, which is common. But you can still tell if the first CO2 when you put it on somebody who's really sick is 20, you know, and they're not coding, and then they're 10, you can still assume, hey, wait a second, maybe I'm overventilating and vice versa. But there's yet one more piece of information that we can get from capnography that's super important. Do you think we could assess if I'm trying not to overventilate a patient so that I don't see this big chest rise like we were all taught in school, right? Right? Do you think I can assess how well I'm sealing the mask with capnography? How would I do that?
Waveform.
Okay? You need the waveform. Can't look at the number, now you need the waveform. Same way to look at pathophysiology like obstruction and reactive airways disease, you need to look at the waveform. What in the waveform can tell you how well you're sealing the mask on the face?
That's high.
Either
Plateaus or if it's peaked.
I mean, we may all be saying the same thing, but it's a little, you know, maybe it's one of those, if you see, know it if you see it. But this is the nice normal square waveform. Now, whether that value is 30, 90, 20, you still should get a nice square waveform if they don't have underlying like obstructive lung disease and the shark fin kind of thing, right? And the distance here, this is the reminder, this is, since we're looking at end tidal CO2, this is when we're breathing out. So this is exhalation, this is inhalation. Exhalation, inhalation, one respiratory cycle, okay? So this can be, long exhalation, this could be longer, but still a square waveform. Shorter, still be what we call a square-ish waveform. This is really important. This number hasn't changed. You're still, if you just looked at the number, you would see generally the same number here. And the respiratory rate hasn't changed that much. But you notice how you no longer have a square waveform. This is leakage of air around the mask. You only get a square waveform if whatever you have a tight seal, whether that's the LMA is sealing well, the ET tube is sealing well, or your mask is sealing well. So I can tell across the room, looking at a waveform, if somebody has a good seal on the mask. Now, I'm only able to tell if the seal is good during which phase of ventilation, inhalation or exhalation? Exhalation. In general, in your experience, is it harder to get a good seal when you're putting air in or when they're exhaling?
When you're in.
Yeah, when you're putting air in, right? That's when you put air coming out around the mask. You're like, oh, okay, right? Because that's where you're applying the positive pressure. So I can't tell you if you have a good mask seal on inhalation, on positive pressure, which is probably when I care the most. But I can tell on exhalation. So what that means to me is that if I have a good seal on exhalation, I may or may not have a good seal on inhalation. But if I have a crappy seal on exhalation, then I guarantee you I have a crappy seal on inhalation. I mean, if I can't even get a good mask seal when the patient is passively exhaling, then I guarantee you that when somebody's trying to drive a breath in there, air is going everywhere but where I want it to go. So it turns out that capnography, and here's a nice picture, this is that the thumbs up grip that I was talking about for massive ventilation. That's why it's so important to have that waveform on there from the very beginning. It gives you a baseline of what their CO2 is. It tells you your ventilation. You can look at it later for your own education in QA to say, oh shit, you know what? I was ventilating too fast. We all do it. Learn from it. Figure out a way to do that better. But super important detail here is how we monitor and the person who's at the head of the bed is most likely the person who needs to monitor that. But hopefully, a lot of times I see on codes, the monitor may be turned away from the person that's at the head because the medic who's running the code wants to see the monitor, understandably, and maybe they're standing at the foot of the bed, and so you often see, patients lying here, somebody here is doing really important work, but the monitor is facing that way. So if you're the person who's bagging, or just, do the seal and the ventilators, it's totally reasonable to ask, hey, can you turn that monitor a little bit so I can see the CO2? I mean, that's taking it to another level if the person who's at the head, BLS, ILS, ALS, is focusing on that as well. Okay. All right. So pitfalls on mask ventilation. It's not always as easy as we would like it to be. Patients who have no teeth. Hard to bag. Some tips. Leave their teeth in. Like sometimes people take their teeth out because they're thinking intubation already. Leave their teeth in while you're bagging. Or in between events, put the teeth back in. We don't normally think about it. Usually the first time you take the teeth out, it goes into somebody's glove and it just disappears off to the side, probably gets thrown out, but there's a disadvantage there. I don't think we do that too often, put them back in, but I sure tell people all the time, no, don't take those teeth out right now. I know you're all excited about your intubation. It's usually, some very excited first year resident who's all set for the intubation. Like, before you intubate, we got to, keep the patient alive. The other thing is there's a technique where you actually put the lower part of the mask onto the lower lip instead of where we would normally put it. Or if it's really an issue and they don't have a gag reflex, just bypass the whole problem and put move earlier to your LMA device. Then you don't have to, the teeth are a non-issue at that point. Another pitfall we have all the time are obese patients. Really hard to get a mask seal if they have a big face. And at the same time, you need more pressure to lift a heavy chest. I mean, if the patient has an extra, 5 inches of chest wall tissue all the way around circumferentially, I mean, think about the pressure to have to lift that chest every breath. And so that's it's kind of a perfect storm of problems. So there have been times where I have absolutely needed 2 people on the mask. We don't always have the luxury of a lot of people, but you can imagine, that's where a ventilator would really help you as well. That position that we showed you very early on about ramping somebody up, taking the weight off the diaphragm can be hugely advantageous in this situation. Now, obviously, that's not a person who's, cardiac arrest on the floor, but if this is somebody that we're transporting. You also could consider an extraglottic airway, like putting in your LMA, if there's a trade-off, because sometimes it can be hard to get a good, sometimes you can get a better seal with a BVM mask on the face with 2 people than you can with the LMA sealing in the airway when you have to generate these really high pressures just to get that subtle chest rise. So there's a trade-off. If you think the problem is I just can't get a seal on the face, and I have had patients who are so obese, and I see people joke about, like, where do you carry your weight? Well, some people absolutely carry their weight in their face, and some of it's because they've been on chronic steroids or whatever it is, and they just have this massive face, and on top of it you add some blood, some vomit, some secretions, you just can't get a seal, then maybe it would be better to just bypass that issue as well with an extraglottic device. Facial hair is really tough. There's what I do not recommend. KY. I was hoping it was going to be something we could tie into this. Breathing problems, right? So 30-year-old male with breathing problems, right? If you get to that scene and he's now a code, bag, non-rebreather? Bag. Okay. All right. And then, of course, if they have facial hair, I'm very quick to just put in right away, put in the LMA instead of trying to fight with getting a seal around facial hair. Okay. Couple last things, and we'll just make this entirely a mass ventilation talk. PEEP. Do you guys have PEEP valves?
Yes.
Do you use PEEP valves? Okay. Do you use them every single time you bag? And I don't know that you need to, okay? This is kind of, again, with optimal ventilation, right? The PEEP valves, which I think, I don't know, do you guys carry them separately or is it just with the ventilator circuit? Separate now, okay. So these valves, and there's different brands. There's some that are blue, there's some that are red, there's some that are much narrower, but they all do the same thing. They're generating pressure when you release the bag, and I'm going to show you a video of this here in a second. And what the PEEP is doing is the same thing that the classic COPD pursed lip breathing is doing. When somebody breathes out, they're generating back pressure. They're creating their own back pressure when they exhale. That back pressure is transmitted all the way down into the smallest airways of the lung, into the alveoli, and helps keep them, we often say, stent them open. Because that's where gas exchange is happening. So PEEP is phenomenal for hypoxia. If I have a patient who's on a ventilator and their SAT is low, I have only 2 things that I think of changing. I either change how much oxygen I'm giving them, and presumably, if their oxygen is low, they're probably already on 100%. But if they're not, I can change how much oxygen I give them. Just like our vent, we can go 50, 100, right? We have more sophisticated vents, you can dial in exactly how much. So I can change how much oxygen. What else can I change? The PEEP. I don't change the rate, and I don't change the volume. Rate and volume control what?
Ventilation.
Ventilation, which is what parameter that I can adjust that to, that I can measure. What do I measure for ventilation? Oxygenation, I measure the SAT. Ventilation, I measure the
Volume.
No, volume and rate, minute ventilation, don't control saturation. Unless you stop breathing for somebody, obviously, but they control what that we just talked about? End tidal. So CO2. Ventilation controls CO2. So if their CO2 is high or low, I adjust my rate and volume. If their SAT is low, I don't adjust my rate or volume. I adjust my how much O's and PEEP. PEEP is all about oxygenation. So if you're bagging a patient whose SAT's 100%, you probably don't need PEEP. We don't have too many of those patients, right? So you could argue for just putting PEEP on everybody that you bag. In the ER, sometimes we're intubating somebody for a head injury, their SAT's perfect, then you could say, okay, we don't need that. How much PEEP? There's a real question as to how much PEEP we should use. In our guidelines, we say for cardiac arrest, we've had some discussions. We originally said 5, and then we put out some guidance of 0. It's a real debate. PEEP is the same issue as positive pressure. The more PEEP you have, it means there's never, the lung's never completely empty. If the lung's never completely empty, there's going to be a little bit of a problem with venous return. So the more PEEP you have, it's the same problem, less venous return. And it's pretty awesome to see. I can put somebody, if I have an arterial line in a patient, I can dial up the PEEP and watch their pressure come down, go down the PEEP, watch. There's a direct correlation within a few breaths. So for somebody who's in cardiac arrest, you don't want to go above 5. I know Dave's looking at his clock. I'll stop here shortly. Okay. I'll leave out all the rest of the slides. Right? You don't want to go above 5 for PEEP in a patient who's in cardiac arrest. You could argue, well, maybe they should have no PEEP. Some people say, well, 5 is about what the lungs like to have, so somewhere, no more than 5 of PEEP in cardiac arrest. Once you get ROSC on somebody, let's just say you get ROSC, let's say it was like a classic, it was an overdose, they probably aspirated, they've got a lot of atelectasis from being down and kind of apneic for a while, you get ROSC on somebody, but now their SAT's in the 70s or 80s, despite the fact that you're giving them 100% oxygen. That's a patient where, unless their blood pressure is in the toilet, let's go up on the PEEP. And you'll see their SAT, in most cases, will come up in a few minutes with the PEEP. So this is a nice video that we took in the anatomy lab at UNM. And patient didn't do so well, as you can imagine, right? But this is an open chest, right? So you can see lung. And here,
we're going to take a little break from the cadavers and we're going to have my glorious go back up and innovation.
okay. So that's how the PEEP valve fits on the exhalation port. So you'll see how much more open the lung stays with each breath, okay? So we're recruiting alveoli, because when we exhale, it's not just shrinking back down, okay? So we're just holding, releasing. Look at how different the lung looks. And I'm going to play that again if, I think this is going to make me, well, let's see if it'll just let me do it. Okay, so that lung is kind of deflated, no PEEP. Every time you breathe, it just kind of goes back down. When we add the PEEP valve, and now we ventilate, each breath you'll start seeing it a little more open, a little more open. That is the term that you hear for recruitment. With each breath, with PEEP, we're opening up more and more of these little alveoli. That's what PEEP is doing inside your chest. Okay, we'll skip over that. Okay. We didn't get past domain number 1, but that's okay, because that is the most important of the domains. So let's just go back to the very first slide and just do, or this one, just as a review. Okay, so turns out, right, there's a lot to this. We were rushing to talk about mask ventilation in an hour, and we didn't cover everything we could cover if we really wanted to expand on these things, and we didn't even get to practicing in this hands-on. And this is, the great thing about this is for all levels. And I hate the fact that this is called basic life support, right? Because that somehow, in a way, devalues it. There's basic life support and there's advanced life support. Advanced life support's got to be better than basic life support. This is just basic in the sense, this is fundamental, this is core. There aren't too many people that have to get an LMA or an ET tube or a crike in the pre-hospital setting that go on to have a good outcome. Let's just be honest. I mean, if you need one of those things in the field, you're having a really bad day, right? I mean, the chances of a good outcome are, from the get-go, are pretty small. But there's a lot of people that get bagged that can have a good outcome. The patients who have cardiac arrest that have the best outcome are the people that we convert before they ever get to an invasive device. You convert them when they're still in the non-rebreather phase, or you convert them when they're in the bagging phase, and they start waking up before you ever put another device in. Those are the patients that have a good cardiac arrest outcome. You can imagine some overdose patients who you need to bag for a little bit and do well, a lot of scenarios. So this is absolutely positively where we save the lives. Anytime we get tunnel vision, whether it's in the field or in the hospital or anywhere, anytime we get tunnel vision on the advanced techniques, patients suffer. We have a thing at the hospital where, we get these DART pages, difficult airway response team. And when a DART page goes out, you get all sorts of people that respond. You're supposed to, you get anesthesia, but you're supposed to get the anesthesia attending. You're supposed to get a general surgery attending. You're supposed to get an ENT attending. The ICU goes, sometimes the ER goes. Every time, this is like absolutely true. Every time that I have gone upstairs in the hospital for a DART page, that I have actually not them just been on a fly on the wall, but I have been, actively leading the page, we have saved the day with bagging. There was always somebody there with a glide scope and somebody with a knife and everybody, and it's like, hold on, just hold on. You'll get to do your fancy stuff, but not yet. And we have just done really, really good bagging. And most of these are situations where somebody was trying to do a rapid sequence intubation. They'd given drugs to a patient, paralyzed the patient, and their SAT is falling, and they can't get the SAT up. And people appropriately call for help, and there's some panic, and that's appropriate. And we just went in, and we're like, okay, let's just do these things. And in those cases, maybe we just got lucky, but in all those cases, we got the, handful of cases, we got the SAT up to a good spot. And then it's like, okay, tag, now you guys can do whatever else you wanted to do, but let's do better bagging. Sometimes the issue of better bagging is to put in an LMA. Sometimes I count that as part of bagging. Because if the problem is you couldn't get a seal, well, just move the mask from here in there. That's all extraglottic is. You're just doing better bagging. You're just creating a seal that's inside that you don't have to constantly maintain. So I kind of put that in the category really of bagging or mask ventilation. It's just the mask in a different place. All right, we covered a lot of ground. It sounds like the thing that probably needs some continued review, and go back and go over this with your crews, capnography and all the things we can do with capnography in particular, and mask ventilation versus non-rebreather for cardiac arrests, okay? And then get out a mannequin and just talk about how you're gonna make sure all these things you can do not to overventilate patients. That's the homework assignment. Any questions, comments, teaching pearls? Since I'm already over time, I screwed up the schedule already, I might as well just keep going. Any teaching pearls? Are there any things that you guys have found work really well, whether it's on a scene or classroom, that just kind of help make any of these points? Okay. All right.
Thank you, sir.
Thank you. We will